from the American Academy of Pediatrics.
A diagnosis of Pediatric Acute Onset Neuropsychiatric Syndrome, or PANS, can be frightening and difficult to navigate.
The AAP Board of Directors has published guidance on this important clinical syndrome.
To families and patients and those who care about and love them that are suffering, we want to acknowledge this. This is real. Your struggle is real, and we want to partner with you in the journey and doing the right thing to have the best outcomes.
But first, it's February, and that means a visit from one of our favorite journal editors.
I would encourage anyone who works in the newborn setting to go and look at the article, because they go through in great detail about the kind of interventions that were done, and all of them are pretty straightforward.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a research roundup from the journal Pediatrics.
David, I am excited for this month's First Up segment.
Is it because there are going to be more jokes about Valentine's Day? Because I got to tell you, Joanna, that Cupid has flown. I have no arrows left in my quiver. My joke book is like last year's box of chocolates. Empty.
It wasn't, David, but I'm glad you were able to squeeze some in anyway. No, you know how we've been asking the digital editor of Pediatrics, Rachel Moon, about her favorite Korean television shows, and the deputy editor of Pediatrics, Alex Kemper, about his favorite children's books?
Oh, I see where you're going with this. For this February First Up, we're going to ask Alex Kemper about his favorite Korean children's television shows. Isn't there a SpongeBob spin-off called Squidward Game?
I really just wanted some more children's books ideas, but now I'm curious if there are any good Korean TV shows. Dr. Alex Kemper, help us out here. What are some ways families can entertain themselves during this cold, short month of February?
You know, Joanna, David, as a Southerner, all I want to be able to do is to survive February. You know, as a transplant now to Ohio, if it weren't for our dog, I think I would not leave my house at all.
As a fellow Southerner, Alex, my heart goes out to you.
Well, Alex, do you have any TV shows you're watching since you're indoors so much now?
I will confess that I'm not watching any Korean television shows right now. I did just watch the next season of the Great British Baking Show. And let me just say, I wish that's the way the world was. Everybody helping out with each other and getting enthusiastic about everyone's successes and helping other people when they have problems. I just absolutely love that show. And I'm not embarrassed to admit that. I also wish that I could bake something, but I can't even make anything out of one of the boxes. I'm like a terrible baker.
I think Pediatrics, Alex, is the closest specialty to the Great British Baking Show that there is. So I guess that's why we're all here.
Yes.
And if there's one thing that I think we can all agree on, it's that another good thing is preventing cancer. And yet, getting parents to consent to human papillomavirus vaccine, a proven cancer prevention measure, can be tricky. Do we have any new information about how to have those conversations more successfully so that we can protect more children?
I'm so glad, David, that you brought up the benefit of HPV vaccine in terms of preventing cancer. It's really one of the most effective anti-cancer treatments that we have. It's just a really very effective preventive medication. And you're exactly right that the rate of uptake of HPV vaccine is suboptimal. There is no one secret to overcoming concern about it and vaccine hesitancy, but this month we're releasing a study entitled a Bundled Practice-Based Intervention to Increase Human Papillomavirus Vaccination, or HPV vaccine. It was a paper that was co-led by Dr. Peter Szilagyi, who's at UCLA Mattel Children's Hospital, and Alex Fix, who's at the Children's Hospital of Philadelphia, and many other co-authors. And what they did was they looked at a bundle of interventions that they tested in 22 general pediatric practices. And the bundle bundle included several different things. It included several online training modules. It included performance feedback about how the individual clinicians were doing around vaccine performance, and also training in how to discuss the importance of HPV vaccine and how to ensure that the workflows in the clinic were such that they would go smoothly to address concerns about hesitancy. And what they found was that missed opportunities for vaccination for the initial, the primary shot, went down by about 5%. And then for subsequent vaccines, it went down by about 2%. And you may say, well, that's not a big difference. But when you think about it at a population level, it really is a substantial increase in vaccination. And when you think about the benefits in terms of preventing cancer, it really does have an important population effect. The other plug I want to make for this paper is that this was a study that was done in the Pediatric Research in Office Settings Network, which is a network that's housed within the AAP, and it represents community primary care pediatricians working together to answer important questions about how to improve care. And anybody at all who works in such a clinic can join the PROS network. And if you just Google AAP PROS, you can find the link for doing it. And I can tell you for the practices that participate in it, the pediatricians who are engaged in the projects, it really is a meaningful thing for them to be able to engage research and answer these kinds of questions that can improve care for everyone. So I would really encourage listeners to think about it and reach out.
And speaking of improving care and protecting children, I think a ton about safe sleep in my work, both in the NICU and the nursery. And when I work in the newborn nursery, I often wonder if the short time I have with families to discuss safe sleep practices actually makes a difference. Is there anything to suggest it might? And what are some ways we can help understand what makes it so hard for families to follow safe sleep practices at home?
You are so right to focus on unsafe sleep, Joanna, because it contributes to about 3/4 of the cases of sudden unexplained infant death. And so, like the HPV conversation that we were just having, a marginal increase in safe sleep can really have profound impact. The other thing that is important to recognize is there are important disparities by race and ethnicity in terms of sudden unexplained infant death. And I think that gives greater importance to making sure that we educate families. And so we're releasing a study this month called the Hospital-Based Initiative for Infant Safe Sleep Practice that was led by Dr. Karen Decker and colleagues at the Pennsylvania Department of Health. And they looked at a whole bundle of things that was done in the newborn nursery setting, including hospital policy related to not only training families about safe sleep, but modeling it within the newborn nursery, providing nursing staff education and parent education. So it was a whole combination of things. And there were ultimately 27 hospitals that implemented this bundle. Now, evaluating the impact of these bundles can be really challenging because when sudden unexplained infant death happens, of course, it's after discharge. And so it's important to find out what families are doing around safe sleep after discharge, and following up families after they've been gotten these kinds of bundles can be really challenging. And what this group did was something I thought was just so clever. They used a regular survey that's done in Pennsylvania, and it's actually done in many other states as well, called the Pregnancy Risk Assessment Monitoring System, or PRAMS, where they follow up with mothers to find out how their infants are doing after discharge from the newborn nursery. And they looked at the questions related to safe sleep, and they were able to compare infants who were born in these hospitals where they were using the bundle to a bunch of other hospitals where infants were not getting exposed to the bundle. And they found a pretty significant increase in safe sleep behavior. So, for example, I'll tell you that sleeping on the back, 36% of those who got the intervention or were potentially exposed to the intervention because they were born in these hospitals, those mothers reported that they were putting their infant on their back to sleep, compared to 17% in those other groups. Now, of course, this is based on self-report, right? We can't go into the houses, and it's very difficult to assess that. But It is a pretty big increase. And of course, we're going to have to wait till they're able to follow outcomes longer to get a better sense of whether or not it changed the risk of some unexplained infant death. But it's a great signal that this intervention really has made an important difference. Now, we did invite a commentary on this one by Dr. Laura Feldman-Winter, who's at Cooper Medical School, and Dr. Ann Kellums, who's at the University of Virginia. And they point out the novel use of the PRAMS survey that I talked about and how we could improve PRAMS to better assess issues related to safe sleep. But the bottom line is that the intervention really does seem to be effective, and that we can use these other systems that we have in place to monitor outcomes, which again, I thought was pretty clever. And I would encourage anyone who works in the newborn setting to go and look at the article, because they go through in great detail about the kind of interventions that were done. And all of them are pretty straightforward. They are the kinds of things that could be easily replicable in other newborn nurseries.
Well, Alex, you and I trained together for a time at Chapel Hill, so I know that you, like me, have been around long enough to start seeing the children of parents we cared for when they were children, which is one of the coolest experiences in pediatrics. That means we've also had a chance firsthand to see how adverse childhood events affect subsequent generations. But outside of our own observations, do we have solid evidence regarding how ACEs in one generation affect the following generation?
Well, that's exactly the question that Dr. Zhu at the University of Calgary and other colleagues in Canada addressed in a meta-analysis that we're releasing entitled Caregiver and Child Adverse Childhood Experiences, a meta-analysis. So as you know, adverse childhood experiences, ACEs, they measure abuse, neglect, household dysfunction. Individual ACEs are pretty common, right? So more than half of us have exposure to at least one of the ACEs. And there have been studies that have been done really starting in the 1990s, but have been repeated elsewhere, showing that the degree to which you have ACEs is associated with a wide range of adverse health outcomes over the life course, including risk of morbidity and mortality. I always like to, when I talk about ACEs, to say that your ACE score doesn't determine what your future is. So just because you've been exposed to a bunch of adverse childhood experiences doesn't mean that your future is closed off. But it does at a population level present an important risk. And what they did in this meta-analysis is they looked at 17 studies that had more than 4,800 caregiver and child dyads. Most of the caregivers were mothers. They had different ways in these studies to assess what the ACE score was in the caregiver and in the child. And the bottom line is that they found that caregiver ACE scores, when they were high, was associated with higher childhood ACE scores. So it's an example of these cycles of intergenerational risk. Just because you're in a cycle doesn't mean that things are deterministic. But I do think that when you want to break the cycle, this is something great where we as pediatricians can really step in. We can think about what are the opportunities, what are the things that we could do, linking families into community services, or just listening and being there as a pediatrician to help address these cycles so that we can improve outcomes. And I'd say one of the things that I think that the AAP has really led the way and done a great job with is promoting trauma-informed care. Certainly you can go to the AAP website and learn a lot about trauma-informed care. Of course, in your favorite journal, we've also published a lot about trauma-informed care. But I think that this is a prime example of things that we can do as pediatricians, generalists or subspecialists, to practice trauma-informed care and really make a difference, break these cycles and help ensure that all of our patients and their families can have best outcomes that are possible. So again, this study to me really underscores the value of thinking about trauma-informed care and of being there for our patients and families.
Dr. Alex Kemper, you've given us so many things we can do to help make our practices better in pediatrics. Thank you for talking to us today. I think tonight might be the first night I watch the great British Bake Off. Do you think my 7-year-old would?
You've not seen any of it at all?
Do you think it's appropriate for my 7-year-old?
Your 7-year-old, highly appropriate, may not make it through the whole hour. My wife sometimes doesn't make it through the whole hour, but it's great. And, I have not seen it, but there's one with children bakers. So maybe your 7-year-old can get teed up for that.
Well, we could at least maybe bake something after.
There we go. And then once you watch it, you'll understand the high mark, the importance of a handshake, and hopefully next time we can give each other the handshake.
Oh, exciting. To read these articles that we talked about today, go to aap.org/podcast.
Coming up, we'll hear from AAP President Sue Kressly about new guidance on Pediatric Acute Onset Neuropsychiatric Syndrome, or PANS. I don't know how many pediatricians listening have had to support a family through the diagnosis of Pediatric Acute Onset Neuropsychiatric Syndrome, or PANS. It's a frightening diagnosis where overnight a child who is acting typically can have surprising and severe symptoms.
I don't personally know any children with PANS. I do know they can develop obsessive-compulsive disorder and change how they eat and how they act. It seems like it can affect so many things.
It can, and for both clinicians and families, PANS may not be the first thing they think of as a diagnosis. The symptoms of PANS can lead to a lot of doctor's visits and testing and having to engage with the medical system, which in and of itself is stressful.
And having to care for a patient who has experienced such dramatic changes in their habits adds to that stress. We need to talk about how we can recognize, diagnose, and treat PANS to help support these families.
We do. And the AAP Board of Directors just released a long-awaited new clinical report on PANS. We're going to hear some of the details from the president of the American Academy of Pediatrics herself, Dr. Sue Kressly.
Dr. Kressly is no stranger to the podcast. We just spoke with her on Pathways to Pediatrics, which aired last month. Sue, welcome back to the show.
Thanks so much for having me, and so happy to weigh in about this important clinical syndrome that can be really, really difficult for both pediatricians and patients and families to navigate.
Well, we are really eager to hear what you have to say. And I don't want to get too deep into AAP inside ball here, but when does the board of directors commission this type of evidence review and clinical report? I know I've seen some of these publications in the past.
Well, some of the clinical reports and things that the Academy puts out really come through our subject matter experts coming to us and saying, there's a gap here that we really need to talk about and elevate this discussion around important items related to clinical care. But occasionally, the board of directors hears from clinicians on the ground, pediatricians like our listeners, who say, help. I need help here. I'm feeling like I'm not very well equipped and I don't have the appropriate evidence-based and evidence-informed guidelines to know how to correctly support and handle a condition. And because this is so complex and involves so many different specialties, the board of directors really thought it was important that we get everyone who's a specialist who touches this in some way on the same page and to really talk about this so that we could have some guidance for pediatricians and families knowing how they can use trusted information that is reliable to do the right thing for the patients and the children we serve.
Well, thank you to the board of directors for taking this on. And I know we also treat PANDAS, or pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. Is this the same or related to PANS?
So this is confusing, and the acronyms don't make this any more helpful. But let's start with PANS really as an overarching umbrella item that really describes a constellation. And I want to be clear, this is the statement in the report actually does say this is a real thing. To families and patients and those who care about and love them that are suffering, we want to acknowledge this. This is real. Your struggle is real, and we want to partner with you in the journey and doing the right thing to have the best outcomes. So let's start with the big umbrella of PANS, of which PANDAS, which is similar symptoms that follow a strep infection, is a subset. The problem becomes it is a small subset. It is not all of the kids who are really affected by the PAN syndrome. And some people confuse the terms and use them interchangeably, and I want to caution everybody not to do that. There is PANDAS, that is proven strep infection, having symptoms of strep and testing positive for strep, that is documented and precedes an acute onset of abrupt neuropsychiatric symptoms. There are other things which are not preceded by strep, and there is no clinical symptom or positive testing for strep, that also can lead to this. And wish we had, boy, do I wish, and so do a lot of people, an easy answer on both how to come to a diagnosis and what did cause it. We think that in some patients, it may be other infections. And let's face it, as pediatricians, we all know kids get a lot of infections, especially early on in their life when they're going to daycare and to school. And so to say things come after infection would be not a surprise because there's a lot of infections, but we have to be very careful when we say it was the infection or the post-infection actually caused something. And there is some literature and some support for some of the causes in some patients are what appear to be autoimmune triggered and not related to either strep or any other infection.
When our knowledge is evolving, one of the hardest parts can just be coming up with a clear case definition for what we're talking about. Do we have a good case definition for PANS?
Actually, we do. And thanks so much for that, because I want to be clear. And I have cared for patients with PANS and walked on this journey, which is never easy, but can result in really great positive outcomes. So I don't want our listeners to lose hope. There is hope in the treatment, and we'll get to that in a little bit, but let's talk about diagnosis. First of all, this is really a clinical diagnosis. And if you go back to your training, where are most of our clues when we make a diagnosis? In listening. So if I have a plea to our colleagues listening to this, please take the time to turn away from your computer and sit with families and listen to what they're telling you. So start with the history and the listening. It is a sudden and dramatic onset. That is the most, I think, important piece of the clinical diagnosis. Literally, families will come to you and say, something happened overnight. This is not my child. And in many cases, if it's a family that you know, you just saw them, you're like, yeah, you're right. This is not the same child that I did a well child check on 2 weeks ago. So let's start with that. It's sudden and dramatic onset. And the two big key items are OCD symptoms or severely restricted eating. Those are the two big categories. And then in addition to that, the clinical criteria are that the child suddenly develops at least two of the following symptoms. So let's go through those symptoms that are included in this diagnosis. So let's start sudden onset, dramatic onset of either OCD or severely restricted eating. And then in addition, at least two of the following: anxiety, sudden extreme mood changes, overreactions, or depression, irritability, aggression, and or severe oppositional behaviors, loss of developmental milestones, maybe acting younger than their age, a decline in school performance, issues like increased sensitivity of senses like sound, touch, smell, hallucinations, learning troubles like dysgraphia or movement or vocal tics, and then problems with sleep or other issues like maybe enuresis that's not explained by another known health problem. And so we really do have a constellation. Now, we also have to remember, PANS is not the only cause of all of those things. So it is really, that's why I want to underscore and put in bold the sudden and dramatic onset to start with.
And what is the pathophysiology of this? Is it like an autoimmune encephalitis?
So for some patient, it appears to be, but that is not true for all. And that's why our plea and the plea of the report was we need research. We need to know better and understand really a lot of the nuances. I mean, this happens often in medicine if you go back, where we think of a diagnosis. And so let's talk about autism, right? Like there used to be what we thought was a clear, this child has autism. And then we realized there's really a spectrum of things, and there are many ways. And so we have to really understand that early on, when we're really understanding what seems to be newly recognized syndromes, that we need more research to get nuanced ability to be able to tell really what causes it. But you are right in that in some patients, this syndrome appears to have been triggered by some autoimmune. And in some patients, it is clear that we really, as clinicians, need to be thinking about what's the differential diagnosis and what else could this be? Because there are other autoimmune neuropsychiatric syndromes, including other things like MDMA receptor encephalitis that may show up in antibody testing, et cetera. So you always want to keep in mind your other alternative differential diagnosis, and in the appropriate patients, do the workup to rule out other things. Now, in the meantime, that should never stop you from meeting with your patients to embark on the journey towards treatment and wellness and getting them back to being their best functioning, happy childhood self. We need people to be listening to their patients and really thinking and doing targeted testing and additional workups with an appropriate differential diagnosis in mind.
So you mentioned that journey and that you have walked it alongside more than one patient. Is there somebody that you can tell us about and tell us what you learned in that process?
Yeah, I've actually treated 2 patients who have had PANS, and the good news is they're both doing really well. But let me just tell you a little bit about one of them. So one of them was after a holiday vacation, a family came in and said that something happened to my child. I don't know what happened, but they're not the same person. And my relatives all told me. So when I went back and talked to them, it was a kid that I knew. And I actually had done the checkup like a month earlier. And we all know that there's a fair amount of school-age kids who have anxiety and symptoms of depression. This was a happy-go-lucky kid who didn't worry about anything. Like that was not the baseline of that child, nor is it a family history. History is important here also. There was no family history of anxiety or depression in this family. So ask those questions. During the holidays, they thought the child was acting a little strangely, but they thought it was because the schedule was off and there were other people living in their house and their whatever. But when the dust settled and everyone left, their family was saying to them, something's wrong with her. Something is seriously not the same as last time we saw her. And they took time to reflect and they're like, you know what? This is frightening. She was doing a lot of counting and she had developed some OCD rituals where she was washing her hands repeatedly, and she had developed some tics and seemed just to be really sort of out of sorts. And so they brought her to me and frightened. And we talked about it. And I said, okay, let's go through your family history, where I learned where there's no history. Asked about recent illnesses. There was nothing. And said to them, look, there is a condition that I've learned about called PANS. It seems to me that she fits the criteria. And they're like, well, how do we find out? And I said, do I wish there was a simple test where I could swab something and just answer the question and you would know 100% what it is and what we can do? I don't have that answer for you. And so what I commit to do is let's get her hooked up with the right people so we can get her on the path to healing, while we take the journey of really watching to see what happens together. And so one of the hallmarks of treatment is cognitive behavioral therapy. I hooked her up with a really good friend of mine who's a really great pediatric therapist. They started embarking on working on her OCDs, behaviors, and some tic management. At some point, she escalated and we talked about, okay, do I send you to a specialist? Who would that be? And of course, in my area of suburban Bucks County, outside of Philadelphia, everybody goes to Dr. Google, and they started, looking about, well, what about this and what about this? And I said, please bring all of your concerns to me. Let's talk about them together, and with shared decision making, let's do what's right for your child. Nobody knows your child like you, and I know your whole family. And so let's make sure that we are doing what is best for your child. And we walked through that. At some point, she actually ended up seeing a neurologist because her tics really started impacting her ability in school, and she was concerned about that. And so we sent her to a neurologist. She didn't end up on any medication, and she's doing fine. But it was a very scary 6 months of really getting to her place where now I would say that she's, fully back to her baseline self.
Let's talk more about testing for PANS, because you mentioned that you really had to individualize it in this case. Is that what you should be doing for every case? Are there studies to always send and others to always avoid?
So the only thing to always do is listen to families, examine the patient, and that includes both a physical exam and a mental health or psychiatric exam. And depending on where you are in the country, and you all know this and so do our listeners, we don't have equitable access to appropriate specialty care all over the country. And so in some areas of the country, the diagnosis may be made in conjunction with a child or adolescent psychiatrist as doing the psychiatric piece of this. But many of our colleagues have really leveled up their expertise and are comfortable with mental health evaluations and some anxiety screening tools, et cetera, in their own office. However, you can get a physical and a mental health evaluation, whether it's in your medical home or in conjunction with appropriate specialists. Those are the always do. The sometimes do, in my head, are two. If the child shows signs of strep in front of you, knowing that PANDAS is a subset of PANS, and I'm talking about fever, sore throat, red tonsils, scarletiniform rash, strawberry tongue sitting in front of you, even you take away the neuropsychiatric acute onset, you would test that patient for strep. So if you were going to test the patient for strep, absent the neuropsychiatric symptoms, then test the patient for strep and treat as we always treat strep for 10 days of antibiotics. Period, full stop. That is what's proven. The rest of the testing really should be as part of, could this be something else? And I want to rule this out in my differential diagnosis. And if that is the case and you're concerned about, for example, an autoimmune encephalitis, that should be done in conjunction with specialists. And they are, again, variable across the country depending on the expertise of people in your community. And that's where that testing comes in. In a small community, you may not be able to get an appropriate child MRI easily. If you're worried about something, or do an LP to look for elevated white cells in the case of encephalitis or meningitis. And so really knowing what resources available and what specialists are available in your community is very helpful. So I would encourage our listeners to really talk about this with their whole practice teams and say, if I come across a patient that I'm worried about this, and this is in my differential, or this whole subset is, where are my resources and what do I have available? And how do I make sure I have the right access for families that need them?
And of course, after testing, we want to think about treatment. So what do we do when we suspect that a patient has PANS to try and make them better?
So you start with where I started with the patient we just discussed, right? Which is appropriate mental health treatments that are known to be effective and safe and work. And the cornerstone of all of that is really cognitive behavioral therapy as a first-line treatment for the many symptoms of the neuropsychiatric symptoms of PANS. And then we know that in some patients, we also have used SSRIs for depression and anxiety in other cases. It also is safe and effective in this realm. Again, there's some pediatricians who are comfortable in that prescribing in that space, and there are others who would rather do it in conjunction with a team that includes child and adolescent psychiatrists. or even neurologists in some areas. So those are the other treatments. There are a lot of families who really are looking at all kinds of alternative treatments. And our systematic review, which the Academy really commissioned as an external review, so we did not introduce our own bias, and our multidisciplinary team that really looked at and wrote the draft for this report came to the conclusion that really none of the other treatments that are talked about online or in the media were shown to be safe and effective. And so for any family who is continuing to struggle despite the first-line treatments, as a mom to a mom, I would say to them, if you're going to go into this arena, please do so in the context of a multidisciplinary team at a center which is doing research, so we can all learn together which of these really do work and which of them really can be potentially harmful to the patient. Again, going back to my family, please bring all your questions to me. Let's start here, because I want to make sure that we're actually not potentially introducing harm and that we're really only doing what is in the best interest of your child.
It seems like we have a long way to go to better diagnose and treat PANS. What would you like to see happen in the future?
I'd like to see happen a couple of things. Number one, that there's wide recognition that PANS really is a problem for families. Number two, that we listen and really create solutions that are family-centered and family-focused and done in conjunction with a coordinated medical home, grounded in the medical home, the people who know you and your family best, and that we work with pediatric researchers so that we can have better information so that we can continue to learn about this condition so that we are optimally equipped to make sure that every child has an optimal outcome.
Well, this is certainly one report I'm sure all of our listeners will want to read. But are there any takeaways you'd like to leave them with first?
I would like to go back to the fact that medicine, and especially pediatrics, is about relationships with people and about partnerships and partnering with families so that make sure that every child gets what they need in the context of their home, their family, their community, and that every child has equitable access to that same level of high quality care, no matter where they live, learn, and play.
Dr. Sue Kressly, thank you so much for joining us today.
Thanks so much for having me. It's always a pleasure.
To read the clinical report, Pediatric Acute Onset Neuropsychiatric Syndrome, PANS, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, everybody knows that February is fig pruning season, right? I mean, you have it on your calendar, don't you?
I didn't know that, actually.
Yeah, no, I thought it was globally recognized. So I actually found 2 fig experts in town online and had one of them come over and teach me how to prune my figs. And best of all, that led to 2 more baby figs being birthed off of the original figs, and I am waiting with bated breath to see if the roots take hold and if I have even more figs this year.
Wow, that sounds delicious.
It should be, at least I figure.
Well, one reason I actually really love February is I am a fan of Valentine's Day because my young children are really into making Valentines, and they're still in the phase where it's a lot of I love you, mommy Valentines. And they've been trying to hide them around the house, but I've found many of them. So it's just things to add to my folder to remember them being this little and this excited about that holiday.
Oh, that is tremendously precious. I love that. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about newborn screening for critical congenital heart disease.
We'll speak with the author of a new clinical report, Dr. Matt Oster. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.